Na 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 na.
Hey, Abba, welcome to JuanMD. My name's Juan. I'm an MD, and on JuanMD, I talk all about living life as a doctor, doing doctor stuff such as taking care of patients, studying, and making the most of my Juan life to live. Actually, this is my very first live stream. Well, it's not my first live stream, but it's the very first successful live stream. That is, if you get to see this come out on like Twitch or anything. Today I'm going to be doing a study with me session. It's my personal philosophy that to make studying effective, you have to make it fun. So the way I like to approach studying is that I like to treat it like a game. And okay, so I treat it like a game and I enjoy what I'm learning, and that way makes it more fun. And you have all these people doing live streams while doing gaming. And so why can't I do a live stream while I'm studying? Granted, I'm using Uworld. And Uworld, we're not allowed to share what's on the screen. And so instead, I'm going to be just taking you through the process. I hope that is cool. So I'm just going through a block that I just did, and I like going through my wrong questions first. That way I drill it into my mind that, that like where I went wrong, like how I can improve my way of thinking, my logic, and my lapses in memory and judgment. So let's begin. So this first case is about a 15-year-old girl who has periorbital swelling. That means, well, there's like swelling around her eyes. She's a cheerleader and she takes an NSAID daily after the last 3 months. For the last 3 months, because she had like sprains and muscle pains during her dances. That's a forced rhyme. I'm sorry, everyone. She doesn't have any chronic medical conditions, and her vitals are normal, and all she has is increased urine creatinine, protein, and albumin. So they did a biopsy of her kidney, and I can't show you the biopsy because, again, Uworld, we're not allowed to share any of this. But on the biopsy, you can see these, what I think were erythrocytes. What I think were these erythrocytes inside the glomerulus. So the diagnosis, it's asking for the diagnosis, and I thought it was acute interstitial nephritis triggered by the use of ibuprofen, but apparently the answer was minimal change disease. I was quick to answer interstitial nephritis because of the ibuprofen and because I saw the red blood cells, but let's see why. Let's see why it was minimal change disease. So MCD is the most common cause of nephrotic syndrome in kids, and on light microscopy, glomeruli are normal. Actually, I should have realized that because her urinalysis didn't really show any blood, even if you could see red blood cells in the histological sample. I guess that's pretty normal because glomeruli, after all, are where blood passes to filter your urine. I guess it would be normal. Let's look at the explanation. She has nephrotic syndrome, probably MCD. It's often, MCD is triggered by NSAID use. In this case, the patient used ibuprofen, but, it's an NSAID nonetheless. Okay, nice. There's usually podocyte effacement. There's effacement of podocytes on electron microscopy, and that's why, that's like one feature you would usually see in MCD. Let's look at acute interstitial nephritis occurs after initiation of NSAIDs, but it causes kidney injury with white blood cells in urinalysis, white blood cell casts in urinalysis. And you wouldn't expect protein in the urine. Okay, nice. Nice. Let's look at the others. Crescentic glomerulonephritis and PSGN cause nephritic syndrome. Okay, crescentic glomerulonephritis happens with Goodpasture disease and microscopic polyangiitis. Okay, those are essentially, well, Goodpasture disease is essentially there's like an autoimmunity against the basement membranes of your body. And then PSGN occurs after a streptococcal infection. Then there's also focal submental glomerular sclerosis, which would demonstrate sclerotic foci in the glomeruli. There's also podocyte effacement on electron microscopy, and this is, however, more common in adults. And finally, membranous nephropathy is also associated with NSAIDs, but again, it's more common in adults. Pretty straightforward. So what am I going to put in my flashcard? Lazy. Let me make a question. Let's go to my stream. How do I edit my stream? Let's add something to my screen. Can I add Anki? As I write flashcards, at least. So, minimal change disease. What are common triggers of minimal change disease? NSAID use, immune conditions, and viral infections. Oh, no. This wrong. Not viral infections. And not autoimmune conditions. I'm sorry. Immunizations. Or malignancy. Okay, let's make some tags. Minimal change and NSAIDs. Malig cancer. Okay, let's add the flashcard. Okay, nice. We're done with this one. Let's go to the next one. Okay, we have a 42-year-old man who was brought to the emergency department. Oh, because he had a suicide attempt. Okay. So which of the following actions of ethanol explains the phenomenon that acute ethanol ingestion can cause paracetamol-induced liver toxicity? Okay, so the answer is competitive inhibition of cytochrome P450. I answered induction of cytochrome P450. This is confusing because alcohol use can actually both induce and inhibit P450. However, the answer here is it inhibits cytochrome P450 in acute setting. In a chronic setting, it can induce P450, but in an acute setting, it can inhibit P450. So acute alcohol use. Acute alcohol use does what? How does acute alcohol use affect CYP 450 activity? It inhibition of CYP450. There we go. Then I have a mnemonic for inhibitors of CYP450. So my mnemonic is 3 C's have 3 zoles. Okay? So my 3 C's are ciprofloxacin, my spelling is malfunctioning today. Oh gosh, what are my others? I know H is isoniazid. Then A is alcohol, in this case, acute use. Then V is valproic acid. Then E, is that ethambutol? Ethambutol? Then Sol. So Zol, Zol, Zol. What are these zols? Oh gosh, I forgot what. Metronidazole. I forgot the other zols. Let me look at my notes. My notes. Where are my mnemonics? My mnemonics. Mnemonics. Awkward music. Okay, oh, it's metronidazole, fluconazole, and omeprazole. Oh gosh, I forgot my own mnemonic. And then ciprofloxacin, chloramphenicol, and cimetidine. Okay. Nice. So alcohol, CYP450, liver. So liver is under gastrointestinal. This overlaps with drug use. So pharmacology. Nice. Next item. By the way, NAPKI happens with impairment of glucuronidation. Actually, the drug that was given to this patient was acetaminophen or paracetamol, right? And there's this condition where glucuronidation doesn't work that much. It's because of a deficiency in N-acetyl P-benzoquine imine, sorry. So that's why it's called NAPKI. Oh no, that's the metabolite, not the enzyme. That's what's formed by CYP450. And you need glutathione in order to metabolize NAPKI. Because too much NAPKI can cause damage to your liver. Okay, let's go to the next one. A 6-month-old boy is brought to the urology clinic for follow-up of undescended right testicle. Okay, so essentially, okay, I can't really show this because of the Twitch guidelines. I can't really show nudity, but I guess I can talk about it. I mean, we're all adults here, and this is not like, what, pornographic or anything. But essentially, the kid has a testicle stuck up in his belly. Because what happens when you're born, if you're a guy? Your testicles are actually ovaries at the start. But because of the Y gene, it's going to signal your body to tell the testicle to descend. But the question is, in the procedure of orchiopexy, where, you take the testicle out of the abdomen, and oh no, it's not in the abdomen. This one was stuck in the inguinal canal. So during this procedure, how the malpositioned testis will be pulled through a physiologic opening in which structure? So the answer was external oblique aponeurosis. I answered internal oblique, which is wrong. Very, very wrong. Okay. So it's not internal oblique because it conjugates to the conjoint tendon and the rectus muscle sheath. And then it forms the cremasteric muscle, which goes into that, and not the aponeurosis per se. So it contributes the cremasteric muscle, not the aponeurosis. The cremasteric muscle, it protects your testicles in the ball sack. Like, there's this like reflex, like if it becomes too hot, then it's going to descend, so it'll protect your testes from the internal temperature of your body. And if it gets too cold, it's gonna contract, and the testes are gonna come closer to your body, and it's gonna warm it up. It helps protect the spermatogenic function of your testes. So, testes develop in the abdomen during organogenesis, and between 8 weeks and 40 weeks, each testis descends from the abdomen to the inguinal canal. So it enters via the superficial inguinal ring. This is an opening in the external oblique aponeurosis. So sometimes the testis fails to descend in a male, and if it doesn't descend, there's an increased risk of testicular cancer and infertility. So sometimes, by 6 months, if the testis can be palpated in the inguinal canal, which again, let's go through the contents of the inguinal canal. It's formed by the external fascia, the external spermatic fascia, the cremasteric muscle, internal spermatic fascia, the superficial inguinal ring, the spermatic cord. Is that right? Let's look it up. What forms the inguinal canal? It's correct. Oh, okay, fine. It consists... Oh, no, these are the contents, but I want to know the layers. The layers. What are the layers of the... Okay. Right, nice. So we have the aponeurosis of the external oblique, we have the internal oblique, we have the transversalis fascia. Oh yeah, that's correct. Okay, yeah, pretty correct. Correctamundo. Right. So... Oh, no, but the question was, it's pulled through a physiologic opening in the aponeurosis of the external oblique. The openings, by the way, are called the superficial and deep inguinal rings. These aponeuroses come from the external oblique and the transversalis. What is the aponeurosis containing the superficial inguinal ring? External. Okay. But I'm gonna make another one. Because, like, it's not enough to have one. Okay. Testes. Okie dokie, kaboki. Let's save this. I'm gonna freeze this because I'm gonna make another question that's pretty similar to this one. So, deep inguinal ring, transversalis. Nice. So, okay. Next question. Okie dokie. What's our next question? A 6-year-old boy has super bleed after an extraction, a dental extraction. So, this should be like a warning, like a red flag for me for like a certain kind of deficiency. But I didn't get it. I got this one wrong. So, the kid also has a history of swelling in his knee joints after trauma. Aspiration of the joints yields blood, and he's diagnosed with hemarthrosis. It's a fancy word for blood collecting in the joint. He has no known allergies, and hemostasis can be achieved by administration of thrombin. That's the answer, thrombin. I answered factor 12, but the answer was thrombin. I was like assuming he would like have an increased intrinsic PTT, which usually reflects a problem with the intrinsic pathway of coagulation. So what's the answer? Oh, okay, the kid has hemophilia. That's a factor 8 deficiency. Okay, yeah. So I was correct. Yeah, that's correct. Hemophilia is associated with a problem with the intrinsic coagulation pathway, because it's usually like factor 8 or factor 9. These are X-linked bleeding disorders. X-linked recessive bleeding disorders. So in this case, even if you do add factor 12, it's not gonna decrease intrinsic. It's not gonna decrease PTT because there's already a deficiency of factor 8 or factor 9, and these are like downstream. So it's like you need A for B, and you need B for C. But the problem is you lack. Wait, no, sorry. You need A and B to make C. We lack B. Therefore, no matter how much A we add, we're not going to have enough C. So in this case, we need factors 9 and 8 to make factor 10, which is like the start of the common pathway. So we need factors 9 and 8 to make common pathway work. But we also need factor 12 to trigger factor 9. However, no matter how much factor 12 we add, if factor 8 is deficient, then, it's not going to do anything. So, to override that, therapy would be to add more thrombin. Because thrombin, after all, is like downstream of the common pathway. And like, if we add thrombin, we're going to increase the blood clotting. Okay, so that is the explanation for this one. In a patient with hemophilia, administration of which factor can the bleed? Let's add some context for this one. A patient presents with heavy gum bleeding post-dental extraction. Administration of thrombin. Nice. Oopie. Yeah, I got this new keyboard, see, but problem is the space doesn't really work that well, and that's very... Maybe I should clean it up. Maybe, like, if I clean it up a bit, or put some oil here, maybe that would smoothen things out. We good. Okay, next. A 25-year-old man. This dude has cystic fibrosis. Cystic fibrosis is essentially a problem with your CFTR gene. And what happens is, because you have a problem with that gene, you have a problem transporting chloride ions. And because of that, well, I have this thing in mind, like, wherever chloride goes, sodium follows. And wherever sodium goes, water follows. And so these patients tend to have dry mucus excretions because there's a problem with, like, the water balance. So the water can't, flow properly. So anyway, this patient has a routine follow-up appointment, and he's had pulmonary exacerbations for the past few years. For the past few years. So pulmonary function will reveal which of the following results. Okay, so I answered decreased FEV to FVC ratio, increased residual volume, normal FVC, and decreased total lung capacity. But, this patient probably has... Okay, so the answer was increased total lung capacity and normal FVC. Okay, or forced vital capacity. So total lung capacity is increased. Why would it be increased? Oh, because of lung hyperinflation. There's air trapping, and that increased air pressure inside your lungs is gonna push it bigger, like a balloon. Okay. Oh, because this patient has obstructive lung disease. Right, because cystic fibrosis, the mucus is more viscous. And because the mucus is more viscous, there are obstructions in your airway. Okay? Nice, nice, nice. The bronchioles, which are the tubes through which your air passes into your lungs, are weak, and these collapse easily. And because of that, the air passes very slowly. There's like a lot of resistance. So instead of being a conduit for your air to move into your blood, it just gets trapped and it inflates like a balloon. So that's why in patients with cystic fibrosis, total lung capacity is increased. And FVC, or forced vital capacity, is decreased. But by the way, like, forced vital capacity is like how much you can breathe in forcibly. But because of the blockage in your airway, forced vital capacity is going to be decreased because you're going to have a harder time to inflate your lungs because there's a lot of pressure. There's already a lot of resistance, air resistance inside your alveoli, so you're not going to really breathe in as much as you want to. So FVC is going to be decreased. However, the FEV1 to FVC ratio is also going to be decreased because FEV1 is like decreased more. So if both your numerator and your denominator are decreased, but your numerator is decreased even more, then the overall ratio is still going to be decreased. So that's why the ratio here is decreased. So our question will be, in a patient who has had a long history of cystic fibrosis, what changes will you expect in FVC and TLC? TLC, FVC. Nice. It's not emphysema. Don't get yourself confused, Juan. Expiration. 2.10. Then cystic fibrosis is a genetic condition, so I'm going to add 1.01. Okay. Nice. Nice. Okay, next. A 72-year-old woman is brought into an emergency department because she has chest pain on exertion. What was I saying? Right. I rephrase these questions because I don't want to be accused of like lifting the text from the question by Uworld. So I like to rephrase it. That way, at least the essence is there, but I'm not like lifting everything as is. You know, I am sharing the process of my studying with you guys and not the questions per se. So anyway, the woman has exertional chest pain and she just came from the Colorado mountains with her family. She's been on vacation. Wow, how do you do a vacation during COVID? Crazy. Let me know how you do it safely in a way that you don't interact too much with other people. She has a history of coronary artery disease, but she has no ischemic symptoms over the past few years. So that means her lungs are working properly. The arteries are patent. Patent is like something you apply for in an office. Anyway, yeah, her arteries are patent, and so she doesn't have any ischemic symptoms. Likewise, she's a lifetime non-smoker and has no history of lung disease. She has mild hypoxemia. That means oxygen in her lungs. Oh no, she's not back from Colorado mountains. She's still in Colorado mountains. She has mild hypoxemia, clear lungs. She has an S4, or a fourth heart sound. It's like there's resistance in your lungs right before the systolic phase begins. So it's like your lungs crack. It's not really cracking. It's more of like you hear the resistance when your lungs are too full. So it like snaps right before the systolic function where the lungs squeeze the blood into the veins. So there's an S4 and there's no extremity edema. There's T-wave inversion. Let me double check. Is that what S4 is for? Yeah. That's right. It happens, S4 happens during ventricular filling, and because of the resistance, you hear it pushing against the ventricular wall. So there's T-wave inversion in the lateral leads. That means the muscle walls are in pain, and their way of telling the ECG that they're in pain is the T-wave is inverted. That's because the electricity isn't traveling properly through the muscle wall. Let's see. Am I correct? Right. Yeah. The T waves don't repolarize correctly in the muscle wall. Instead, they remain depolarized, and because of that, they invert. So there's elevated. Oh, no. Troponin and D dimers are within normal range. Okay. She's an elderly patient, right? So what the question is, what changes contributed to her increased susceptibility to this T-wave inversion? So decreased chest wall mobility. Okay, this one I don't understand. Let's see. Okay, high altitude, hypoxemia, physiologic response will be hyperventilation, right? Your body's trying to breathe faster in order to get more oxygen. She's not able to compensate for hypoxemia at a high altitude because she's an older individual, she's elderly, and there are a number of, there we go, age-related changes in the respiratory system. So what are these changes? Poor chest wall compliance. Okay, because she's old, there's probably spinal degeneration changes, she probably has kyphosis, or rather her thoracic cage is kind of big, but that means there's more resistance when your chest wall expands, because it's already stretched out. Also, there's less elasticity in her alveoli. So there's more air trapping, there's enlargement, kind of like the cystic fibrosis case we read earlier. Well, I read earlier and told you guys about. Then there's an increased alveolar arterial gradient. Okay, because there's less O2 in the blood, but the alveolar O2 is pretty much the same. And so the difference between O2 is increased because there's less perfusion. I mean, you can ventilate as much as you want, but the perfusion isn't that effective. So there's more dead space. So at a higher altitude, the body will try to hyperventilate in order to compensate for the decreased oxygen. However, because of her age-related changes, she's less able to compensate. That's why she's probably experiencing this angina, especially because she already has a history of ischemia. Coronary artery disease, rather. Okay, so what make it more difficult for elderly patients to acclimatize to higher altitudes? Okay, so we have the decreased stress while composite with the kyphosis. What else? Yes? Next question. We have a 12-year-old boy. He's brought to the office by his mom due to headaches and gait instability. So essentially the kid has problems with his head and gait instability. Okay, okay. His symptoms began several months ago. These have worsened. Okay, the question shows an MRI of his brain. And okay, in the MRI, I can appreciate that the kid has a really big cerebellum, and the ventricle seems to be enlarged, and so there's like a white collection inside the border of said ventricle. So there was, I thought I answered ependymoma, but apparently the answer is a pilocytic astrocytoma. Okay, so because a pilocytic astrocytoma is the most common kind of brain tumor in kids, and it's a well circumscribed, this is a mouthful, well circumscribed cellular mass. Okay, so yeah, the lesion was kind of round, and yeah, the white collection. Okay, let's see why it's not an ependymoma. It arises from the ependymal lining, hence ependymoma of the ventricle, and it usually occupies the fourth ventricle. Okay, it causes hydrocephalus, which I guess is understandable because his cerebrum didn't have any inflation, I guess. Okay, so pilocytic astrocytomas are low-grade tumors. These occur in the cerebellum. These are well-circumscribed lesions of both fluid and solid components. Okay, so hence the white collections would be the solid part, and then the dark collections would be the fluid part. And these stain positive for glial fibrillary acidic proteins and Rosenthal fibers. Nice. Alright. Nice. And then majority of patients can be treated with surgical resection and have a good prognosis. Nice. Sweet. So what question am I gonna make? What question? I'm gonna type cerebellar cyst with fluid and solid components in a child who presents with headaches and gait ataxia has gait ataxia, instability. What type of brain tumor? Nice. So this is a 1.04, and it's in neurology. 106. Okay. Sweet sauce. Next, we have a 2-year-old boy who immigrated to the US, and he's brought to the office because he is crying and he's irritable. He's 2 years old. He was delivered by a CS, or cesarean section, and his head circumference is at the 95th percentile. So they did a CT scan of the head, an axial CT scan, and you can see a dark collection, a dark formation at the posterior portion of his brain. So what was the diagnosis? I answered Arnold Chiari, but the answer apparently was Dandy-Walker malformation. So a Dandy-Walker malformation is caused by absence of the cerebellar vermis. He looked like he had a vermis to me, I guess, but I guess not. What does the cerebellar vermis look like on CT? Cerebellar vermis. What does it look like? CT. I must share the picture here. I mean, this is a Google search after all. Oh. Okay, just so you have a reference. This is Radiopedia. That's what a normal cerebellar vermis looks like. And this is what a Dandy Walker malformation. Okay, so it's perfectly clear now. Okay, so that is an absence of cerebellar vermis. Nice, okay. Nice, nice. What causes a Dandy Walker? There's hypoplasia of the cerebellar vermis and cystic dilation of the fourth ventricle. I didn't see the dilatation. There's posterior fossa enlargement. Alright. So patients often present during infancy with developmental delay and progressive skull enlargement. Cerebellar dysfunction manifests in unsteadiness, poor coordination, and there's non-communicating hydrocephalus. Because of the foramina of Luschka and Magendie. These are the foramina by which the fourth ventricle exits into the spinal canal. And this causes increased ICP. So that's why this kid was irritable. Crying. I can imagine how that feels. Must feel terrible. Okay. An absence of the with fourth ventricular dilation is called what term refers to an absence of Dandy Walker malformation? Okie dokie, kabuki. Next. Okay, next question. We have a 50 stutter. We have a 55-year-old man, and he presents to the hospital because he has abdominal pain and black stools. Okay, he's smoked cigarettes daily for the past 30 years. Not a good idea. And he's administered intravenous drugs in the past. I would say that's a bad idea if this is illicit intravenous drugs, but there are cases in which IV drugs are, well, prescribed, I guess. Can't really tell. This patient is treated empirically with a proton pump inhibitor, something like omeprazole. Okay. So, there's no source for the bleeding, symptoms resolve, and the patient is discharged. Oh, by the way, the patient has a history of asthma and hypertriglyceridemia, and he's medicated for that. Several weeks later, he presents again, this time to the ER. He has high temperature, he has weight loss, and muscle pain. Weight loss is always bad if this is like unplanned weight loss. And then after initial evaluation, we can see that there's transmural inflammation of the muscles. No, transmural inflammations of medium-sized arteries in muscle biopsy. And then the arterial walls are eosin staining. There's also necrosis. So that means there's like protein collections. And then there's disruption of the internal elastic lamina. So which of the following is a predisposing factor for this patient's condition? And the answer is viral hepatitis. I answered smoking. Actually, 41 people out of 100 answered viral hepatitis, and 40 out of 100 answered smoking. So it's a very close match. The answer is polyarteritis nodosa. Okay, and that's a vasculitis of the medium-sized arteries, particularly in the muscle. Okay, there's segmental transmural inflammation of the laminae. There's fibrinoid necrosis, and there's disruption. Excuse me. This disease is not associated with antibodies, but these are associated with immune complexes. So the immune complexes deposit themselves in the arterial wall, and there's also high counts of C-reactive protein, as well as increased erythrocyte sedimentation rate. These are signs of inflammation. And usually these are associated with viral hepatitis. I guess I made the mistake of answering smoking here because a lot of the vasculitides are associated with smoking. But in this case, I guess, polyarteritis nodosa is more associated with viral hepatitis, particularly hepatitis B and C. Is that a word? Is vasculitis a word? I know vasculitides is a word, but is vasculitides a word? Let's see. Yes. Yes. That is right. No. Vasculitis is a word. I am coming up with neologisms. What's wrong with me? Okay. Next. Okay. A 72-year-old woman comes for a follow-up. She's accompanied by her son. She's had progressive memory loss for the last 2 years. The son is like, oh, she used to be so independent, but now she needs help with everything. And she even forgot my name. That must be so painful if your own mom forgets your name. Oh well. So MRI reveals diffuse cortical and hippocampal atrophy, which changes contributed to this patient's condition. There is decreased acetyltransferase activity in the nucleus basalis. That's the answer. My answer was increased acetylcholinesterase activity in the caudate nucleus, but apparently that's wrong. I was on the right track because in mind I had Alzheimer's disease, but I guess I got the pathology wrong. Okay, there's a decrease in acetylcholine, which is kind of associated with acetylcholinesterase. Alexa, stop. But in this case, in the case of Alzheimer's disease, it's because of choline acetyltransferase deficiency. This happens in the nucleus basalis of Maynard and the hippocampus. Right. Okay. Nice. Alright. Let's look at the other ones. Substantia nigra, dopaminergic neurons. Those are associated with Parkinson, as well as Lewy body dementia. Raphe nuclei. These are part of the serotonergic system, or the reticular formation. And lack of serotonin is implicated in anorexia, depression, and sleep disorder. Sleep disorders. Then the caudate nucleus is implicated in Huntington disease. The caudate nucleus doesn't work in Huntington disease. Then finally, the locus coeruleus, norepinephrine. It's implicated in panic attacks, panic disorder. Yes. Okay, next, we have a 70-year-old white woman. She's brought to the ER because of hip pain. Ooh, she fell with hip pain. Essentially, the question is, why is she more susceptible to hip fracture? The answer was trabecular thinning. I answered subperiosteal bone resorption, but the answer was trabecular thinning. Okay, bone resorption, subperiosteal bone resorption is associated more with hyperparathyroidism. But trabecular thinning, it's more of the aging thing in osteoporosis. Nope. Nice. Nice suit. Alright, next we have a 20-year-old woman. Oh, I love 20-year-old. I mean, that was my favorite age. That was how long ago? It was so long ago. It was centuries ago. She comes because of pain and swelling in both knees for the past 3 months. Okay, she has no discharge, she has no fever, she has no chills, not sexually active. Okay, we can rule out syphilis. She has increased blood pressure. There's tenderness of the knee joints. There's no effusion, so it's not swelling. No, it is swelling, but there's no effusion. What do they mean by no effusion? Remainder shows no abnormalities. Which pathologic mechanism? Oh, no, wait. Before that, she has anemia, thrombocytopenia, and hypercreatinemia. Which mechanism is responsible for her kidney disease? Interesting. So the answer was immune complexes containing DNA and anti-DNA antibodies. Does she have lupus? Oh, she has lupus. Okay. I answered autoantibodies to podocyte antigens. Uh-huh. My thoughts were membranous nephropathy. However, mhm, mhm. Okay, because the urinalysis of this patient showed red blood cell casts and proteinuria. In membranous nephropathy, there are no red blood cell casts, or at the very least, these are unexpected. Okay, so lupus is associated with immune complex deposits. So mnemonic for lupus is hematologic, but hystremic. Systremic. So cyst3, type 3 hypersensitivity for systemic inflammation. But for hematologic inflammation or red blood cell destruction, that's type 2. So it can present two ways. Okay, so it's a type 3 hypersensitivity reaction. At least lupus nephritis. How could you tell, though, that this patient had lupus? Okay, let's go back to the case. She has tender knee joints. There's no effusion. Uh-huh. Uh-huh. I guess the only thing is the red blood cell casts. Okay. Nice to... Okay, I don't have a lot of flashcards on SLE, actually. Okay, next up. We have a 35-year-old man who is evaluated for fatigue and shortness of breath. Recently, he's had bilateral leg swelling and abdominal distension despite the overall weight loss. He doesn't use tobacco, alcohol, he doesn't use drugs, illegal drugs. Thank you, my friend, for living a healthy lifestyle. And what sucks, though, is sometimes patients, you try to avoid these lifestyle factors and yet somehow you still end up with diseases. It's kind of sad. That's why we're here. That's why we are here to help. We doctors are here to help. Despite treatment, the patient dies several weeks later. There's endocardial thickening. There are dense fibrous deposits around the valves, particularly the tricuspid and the pulmonary valves. There's pulmonary valve stenosis. And the left and right chambers are normal. Okay. How would measuring urinary 5-hydroxyindolacetic acid help in the diagnosis? Because I honestly didn't know. I answered homocysteine. Okay, this is carcinoid syndrome. Okay. Endocardial thickening and that's gonna be redundant. R, Juan. It's R, not is. Why aren't you grammaring properly today? Let's see. Okay, carcinoid heart disease. Check it out. Okay. Why though? Is there regurgitation? Is that pulmonary stenosis? Pulmonic. Oh, okay. So it's pulmonic valvulopathy. Doesn't say which one in particular. So I guess I'll just put pulmonary then. Okay, what is a carcinoid? A carcinoid is a well-differentiated neuroendocrine mass. This is usually found in the small intestine and colon, particularly the distal part of the small intestine and the proximal part of the colon, and it can usually metastasize to the liver. Okay. Well, it makes sense because like the venous drainage of the colon would like go into the liver. Okay. These tumors secrete histamine, serotonin, and vasoactive intestinal peptide. These are then metabolized in the liver, then brought to systemic circulation. Okay, and then this causes carcinoid syndrome. Oh, okay. So in the heart, excess of serotonin can cause fibroblast growth and then fibrous tissue deposits, causing the enlarged endocardium, and then the tricuspid regurgitation. Okay. Okay. And then when the body metabolizes serotonin, this yields 5-hydroxyindolacetic acid. Oh, and that's how you would suspect carcinoid syndrome. Okay, it's all making sense now. Okay. In patient. What signs did this patient show that would have made you suspect carcinoid syndrome? Okay. This is a very simple question, although it's disguised as a multi-layer question. As a flashcard, it should work. Okie dokie. Do I have any questions in the chat? Oh, someone's watching. I wonder who's watching. I'll go to the next question. I'm like using up too much time. Oh, wait. But first, let's go to the other items. Let's see why homocysteine is wrong. Okay. Inherited elevation or increased elevation of homocysteine levels is associated with arteriovenous thrombosis and atherosclerosis. Okay. Right. How about this? Cortisol. Plasma cortisol is used for, well, Cushing syndrome. Then phenylalanine is elevated in phenylalanine hydroxylase deficiency, which can cause it to deposit in your brain tissue and cause brain disability. This is usually heritable. Then porphobilinogen is a porphyria-related parameter, and this is because of defective heme synthesis. Okay, I know that that wouldn't have been my answer. I also canceled out vanilla mandelic acid because of norepinephrine problems. Because like you metabolize norepi, it becomes vinyl mandelic acid. You use it to detect neuroblastomas and neural crest tumors. Alright, let's go to the next question. Right. I knew this patient had giant cell arteritis. By the way, giant cell arteritis is a problem with your vessels in your brain, particularly your temporal lobe. Causes huge headache. But okay, this patient had ache in her jaw. She had malaise, dimming vision in her left eye, and she had muscle aches in her hips. What's the initial test that we should do in this patient? I answered angiography. Because I thought, well, arteritis, you should do an angiography. But in this case, we should do an ESR. ESR is an inflammatory marker. But why should we do an ESR? Right. If you suspect giant cell arteritis, there is associated CRP, C-reactive protein, or ESR. These are non-specific, but these are always elevated, or almost always elevated in temporal arteritis. And patients who have elevated CRP and ESR in such a presentation should have an immediate biopsy of the temporal lobe artery. Temporal lobe artery or the temporal artery? I think it's just the temporal artery. Angiography will show arterial narrowing, but it's not as sensitive as ESR or CRP. That says it. ESR or CRP. What tests should be done? ESR or CRP? Nice too. C1, giant temporal lobe, vasculitides, ESR, CRP, inflammation. Let's go to the next question. Okay. So a study was done in animal models to assess morphologic changes in cerebral pathology. So an inciting event shows highly eosinophilic cytoplasm and condensed basophilic nuclei. That means the cytoplasm is pink and the nuclei are blue and condensed. So they did serial biopsies to assess the changes. Which of these are associated? No, which of these are seen in the brain in the weeks following the brain pathology? The answer was glial cell hyperplasia. I answered fibroblast migration. This occurs in the peripheral tissues of the body, but not the CNS. Right, because the glial cells are the macrophages of the CNS, and these are going to eat up all of the debris. Oh, but more than that, they also gliosis. They also proliferate to replace the lost neurons. And then when they connect, they form a gliotic scar. The microglia, I'm sorry, it's the microglia that do the phagocytosis. It's like the small guys who have to do all the dirty work. The big guys, they hug the space, and we small people have to do the dirty work. Right. So, okay, CNS injury is associated with hypertrophy of the astrocytes and gliosis, forming a glial scar. Which cell? Let's make it which cell compensates for loss of cell type? Right. Right. Okay. Next mundo. Okay, so we have a 60-year-old dude who comes to the office to discuss sexual symptoms. Which makes me wonder, I mean, like, since there are so many sexual dysfunctions in medical topics, should I make my channel restricted? No, but this is like science stuff. It's nothing like explicit, I guess. So 8 weeks ago, the patient was admitted for a non-ST elevated myocardial infarction. They put a stent, and then since discharge, he has had difficulty maintaining it, if you know what I mean. And he also has slow... What's the correct term for this? He shoots slow, I guess. I'm not sure if I can say the EJACULATION on a live stream. But oh well. His libido is normal. He has regular nocturnal sticky uppy, I guess. Now he has no cardiovascular symptoms, and he can walk upstairs fine. So, which of the following is the most likely cause of his sexual dysfunction? I answered metoprolol, because he takes metoprolol in the case. It said he takes metoprolol, but the answer was psychogenic. So why is this psychogenic? Okay, psychogenic erectile dysfunction is common in patients with mood disorders and can also occur abruptly after an inciting stress event. So in this case, the non-ST myocardial infarction, but what in the history implies a pre-existing mood disorder? Nothing. Okay. So, essentially, it was the stressful event, which was the ST, elevated myocardial infarction, that predisposed to the psychogenic sexual dysfunction. In this case, severe acute illness. Okay. It can also be caused by prolonged illness, like what? Diabetes, tuberculosis, and this can make patients nervous about how to initiate, I guess, surgical procedures, like, because patients will be like embarrassed, say by they have a scar on their body or like a colostomy bag, so they're going to be embarrassed, and it's going to make them, you know, they'll have a hard time. They'll be like really conscious while doing the deed. And then loss of a loved one can also cause this. Right. This is often situational. So the normal nighttime pointy pointies. Oh, that's the clue, hinting in at the psychogenic erectile dysfunction. Because if those weren't normal, then you would guess maybe it's a medication side effect. But in this case, it's not. Okay. And that is the last of my incorrects in this last block of Uworld. Okay, that was fun. I mean, I liked going through it with you guys. So that was my first live stream on my channel on Twitch. So, what do you guys think? Did you like it? Did you not like it? Or did you not like it? Tell me in the comments below. Well, if this is on YouTube, I'm gonna transfer this to YouTube eventually, in like 24 hours. Cause like Twitch, you can't put it on another platform within the first 24 hours of streaming. Anyway, if you like this video, click the thumbs up, subscribe to my channel, click on the bell for further videos. Until next time, guys, this has been Juan. Remember to always live life to the fullest, because you only have one life to live. Play the outro. Doo-doo.